It is just a huge honor for me today to be podcast interviewing Dr. Fotinos, Sarantos, Panagakos, DMD, PhD. He received his DMD from University of UMD-New Jersey Dental School, which is now Rutgers Dental School. My God, that's pretty bad dental school that has to go in the witness protection program and change your name. And his PhD in Biochemistry and Molecular Biology. The dude is a double doctorate. It's amazing how intelligent this guy is. He received his master's in education from Seton Hall University in 2007, master's in business administration from Lay University. He was commissioned in '86 as a second lieutenant and served for 13 years in the New Jersey Army National Guard and Army Reserve, departing as a major in 1999. From '93 to 2005, he served full-time faculty at New Jersey Dental School in a number of administrative and academic positions and maintained a private dental practice. From June 2000 until 2007, he served a number of roles with increasing responsibility at Colgate-Palmolive Company, where you were focused on clinical research, scientific affairs. In fact, that was the last time I saw you, wasn't it? It was at Colgate?
In person, yeah.
Yeah, and that was, it's pretty cool when the street's named after you. Isn't their address like 1 Colgate Boulevard or something like that? Yeah,
no, the headquarters is on Park Avenue, so that's not Colgate Ave.
Oh, okay. And November in 2017, you joined Geist Pharma North America as Vice President of Scientific and Clinical Affairs in Princeton, New Jersey, where once again you led the U.S. clinical science teams related to the development of clinical studies, publications, etc. I mean, I could read. Since August 2018, you served as Associate Dean for Research, West Virginia University School of Dentistry, where again it was in research. And then in 2020, you assumed the role of Vice Dean at WVU. And now you're appointed Interim Dean. Are you Interim Dean now or the
yes.
full? You're the Interim Dean?
Yes.
So what does Interim Dean mean? That means that you're the Dean until they find someone who wants the job, or you don't want the...
Correct. There is actually a search going on right now for the permanent deanship.
And would you? I mean, do you want that job? I mean, what would it?
Yeah, I'm a candidate, and they're going into the second round of interviews this month, and I'm one of 3 individuals currently under consideration.
Well, my gosh, I don't even know where to begin with you. I mean, you're a double doctorate. You know everything from clinical to molecular biology. I got to start with the pandemic, though. There's about a 6-page long thread on Dental Town says, would you take the vaccine? So my first question, Foti, is would you, with 2 doctorates, molecular biology, all the research, would you take the vaccine?
Yeah, actually, I got my first dose 3 weeks ago, and I'll be getting the second dose next week.
And did you have any side effects or symptoms?
Well, I had some arm soreness at the site of the injection about 24 hours after getting the injection, and it lasted about 48 hours after that. It felt like, the way I describe it, it felt like someone punched my arm with a brass knuckle, but there was no bruise. So it was really soft tissue, inflammation, probably from some of the components of the vaccine, interacting with the tissue. And the night of the vaccination, the first vaccination, I did feel a little fatigued at the end of the day. I wasn't sure whether it was I was just tired or related to the vaccination. So that was pretty much the extent of my side effects.
And could you give the dentists any talking points for their staff? There's a thread on Dental Town. My staff have declined COVID vaccine, and I mean, it's a range of emotions. I mean, we know, heck, a quarter of America is anti-vax. I mean, they were anti-vax a decade before
right.
the pandemic. What and should it be an emotional, upsetting thing for the dentist? I mean, is it okay if your assistant doesn't want it and you just say, okay, she doesn't want it? Or what advice would you say to an owner-operator dentist with a staff of 5 and 3 of them don't want to take the vaccine?
Well, I think, again, it's up to each individual to make that decision. However, when it comes to a place of employment, I think it's whoever's, place of business it is, especially in a healthcare setting, to kind of set the rules. And so the dentist, if they're the owner of the practice, just like if they require any other sorts of vaccination, whether it's Hep B or MMR or any other getting the flu vaccine every fall as a requirement for being employed in the business, this will fall under that category. I think legally right now, Howard, we can't require it because it's still under an emergency use authorization from the FDA. However, once it moves into a full approval status, it can become no different than the Hep B vaccination, which, for example, here at WVU, if you're in the healthcare part of the university, that's a requirement. You need to get vaccinated for Hep B. So it could become a requirement from an employment perspective from the institution. But again, I think it comes down to each practice making a decision. The vaccine protects you. We don't know yet whether the vaccine, the research hasn't been done yet to the extent where if you are vaccinated and you get exposed and you actually have virus, but you're fighting it because you have an immune response, does it reach the level where you can still be contagious to somebody else? Right now, it doesn't appear that's the case, but with more work, we'll determine that. So probably a long-winded answer to your question. I think it comes down to individual's personal decision, and then for the dentist employer, it comes down to how they want to manage their practice.
Well, we have far more listeners around the world than we do in the United States, and around the United States, they don't know what West Virginia is because it doesn't have a football team. So for around the world, he's kind of south of the Pittsburgh Steelers.
We do have a football team. We have the WVU Mountaineers. We have a Big 12 football team. We don't have a NFL team, but that's our NFL team, and they're actually pretty good.
Well, he's just south of the Steelers. He's to the west of the Washington. My gosh, the dental school, I mean, it must be an amazing amount of responsibility for you to be in a pandemic, and the kids want to treat patients. And I remember the graduating class of 2020, I was talking to this kid, and she was crying because she didn't get to do one root canal on a live human. And wow. So this is so challenging for you. So where are you at now? What's the attitude at West Virginia University School of Dentistry? Are you... How back to normal is it compared to pre-pandemic?
Well, maybe I can go back to when we first kind of, got hit with it back in March of last year, and kind of bring you to the present. It might help explain where we are today. So back in March, our students were actually on spring break when the university decided to go remote for all of the lecture courses, and they shut down our clinical operation in the school. We did maintain emergency care services. So we had our emergency urgent care clinic where we triage open, as well as we had the endo department, the oral surgery department, the residents, and also some of our specialty programs provided support for any emergencies that came through that were of a specialty nature. And we remained in that capacity through the middle of May. Students were not in the clinic. We had some residents, like I said, and it was primarily a small core of faculty that were still on site providing care, triage, and care to patients, because a lot of the practices in our area closed down, and some of them were not even seeing emergency patients. So we were, a safety net for many individuals. That proceeded through the 18th of May. During that 2-month period, we still had a fourth-year dental class that had to graduate. Fortunately, they all had taken their board exams in February before the pandemic hit, so they had all kind of completed the clinical portion of their board exams. We had a couple that had to make up a couple of sections that they didn't pass, and they were able to do that after the fact. And then most of them were done with their clinical requirements and competencies at that point. We had a select group of students that still needed a few things, and our faculty were able to create either simulations or optional activities for them to complete those exercises. So from a Commission on Dental Accreditation standpoint, we met our standards. We provided all that documentation to CODA. May 18th, we reopened at a 50% capacity, and we proceeded in that sort of situation, both in our simulation lab as well as in our clinics, through the end of July when we finished the summer session. When we came back in August, we were back to full capacity in both our simulation lab as well as in our clinics, and we've been operating in that capacity ever since. So we've been, seeing regular patients normally without any restrictions relative to scheduling since August. We have put into place certain mitigation steps within our clinical program. We try to have all the aerosol procedures occurring in a certain part of the clinic. Students are required to have an assistant if they're performing an aerosol procedure. They're wearing KN95 masks and a face shield pretty much for most of, if not all of their treatment, regardless. We've made sure our ventilation is up to snuff within the building, HEPA filtration. We've done a lot of the, sort of environmental steps that a lot of other schools have taken as well. And we've been operating like that since then, and thank God, and knock on the wood here on the desk, we haven't had any transmissions occur within the clinical setting here at the school. We also do an excellent job of screening patients as they're coming in, both from a medical history perspective as well as a temperature check. Although some people argue the temperature check isn't really that valid, we still are doing it because we feel it is a vital sign, so we're taking it anyway.
Well, I mean, this aerosols and lungs, this isn't your first rodeo. I mean, you've been researching lung disease in dental professionals. I mean, my gosh, you were Fotinos, Panagakos. Did I say that right? Panagakos?
Yes, you did, yeah.
I'm sorry, I'm so linguistically horrible. But Associate Dean of West Virginia is collaborating with the National Institute for Occupational Safe and Healthy to study how microscopic airborne particulates and gases might be generated during dental procedures. This is pre-pandemic stuff.
Right.
And over the years, Foti, I mean, I don't know if you'll even believe this story, but you'd have to, when we were in dental school, we would wrap asbestos in the casting ring, and then we would put our wax up in there, and then we would burn it out, and we'd pull it out. The thing was glowing red asbestos, and then we'd quench it. And some people think that, some dentists think, it seems like whenever a dentist gets lung cancer and wasn't a smoker, they always go back to their asbestos use 30, 40 years ago. Do you think that's not correct, or what do you think of all those years that we heated up asbestos till it turned red?
Well, I think there's a lot of things in our history as dental professionals, Howard. As you know, there was a time when we would mix mercury and silver fillings in our palms of our hands, right? In order to make an amalgam.
I have to interrupt you. When I got out here in '87, my friend bought some old guy's practice that retired that had carpet in the operatories. And he asked me to come over on Friday night, help him pull up the carpet. We pulled up the carpet, and on the cement were balls of mercury that you could kick, and they would hit the wall, split in two. I mean, oh my God.
Yeah.
So
I think in the past we've done certain things because we didn't know any better. We didn't know what the risks are and what the consequences were. I think when it comes to inhalation of particulates within the practice, I think we're subject to it. I mean, we're grinding things, we're polishing things, we're smoothing things, and whether there's an aerosol or not, many times we're wearing a mask, but is the mask really providing a full 100% protection? Are there openings? So the study that you mentioned is actually a collaboration with NIOSH. NIOSH has a facility here on the campus of West Virginia University. It's the only NIOSH facility in the country that's actually co-located with a university. And so it has allowed us to do a lot of collaborative projects. A couple of years ago, when I first arrived here at WVU, the folks at NIOSH reached out to me and said, there was a recent publication in MMWR, which is put out, Morbidity and Mortality Weekly, which is put out by CDC, about a case, a rash of cases of idiopathic pulmonary fibrosis in a hospital system in Virginia. And when they looked at the data, the occupation that had the highest number of idiopathic pulmonary fibrosis cases among all the occupations were dental professionals. And so that got to them thinking, what is in the dental environment that could be contributing to this? Because there's no cause. It's idiopathic, so we don't know what the cause is. So we had set up a study where they were going to actually, both at the school and in some private practices, measure the air quality as we were doing what we do every day. As you're grinding a denture, as you're adjusting, a restoration, as you're, preparing a cavity preparation or crown prep, and measure the air quality to see what they could detect. And we were just at the point, Howard, where we calibrated all the instruments in the clinic. So we were ready to go. And we know what happened in March of last year. So we had to put the study on hold. So we're hoping that once we come out of COVID and we're able to restart the study, we'll be able to get to that. So that's the background of the study that you just mentioned.
I know you've been to the CDC in Atlanta. I've been down there. I mean, I kind of feel sorry for them. So when I listen to these anti-vaxxers, they say, the CDC, they're just shills for the pharmaceutical industry, blah, 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 blah. My God, all I ever met was some of the hardest working dentists in my life who were begging for the smallest amount of equipment that could have made far more money. I mean, the general dental practices, they guarantee a day rate. I guarantee the day rate's higher than anybody's making at the CDC. What attracted you to research? I mean, you've always been a clinical dentist and a researcher. I mean, you have 2 doctorates, and where does that come from?
Well, actually, I got interested in research when I was doing my undergraduate baccalaureate training at Lehigh University in Bethlehem, Pennsylvania. And I did some research as a 3rd year and 4th year student there. And when I got to dental school, it's kind of a funny story. One of the biochemistry faculty, remember the lectures in biochemistry, Howard, where you had a lot of different faculty come in and each one taught sort of their area of the biochemistry. Well, the faculty member who was teaching us enzyme kinetics, Dr. Suryendra Kumar, he, at the end of one of his lectures, said, oh, by the way, if anyone's looking for work, I need a work study student to help clean some glassware in the lab. And at the time, I was looking, to help, with expenses, and I was eligible. So I went and worked in his lab, and I was cleaning lab glassware. And after some discussions, he found that I did research as an undergrad, and said, hey, would you like to do some work in the lab on research? And so I started to help one of the postdoctoral students there doing some of their research. Before you know it, they hired somebody else to do the glassware, and I was doing, benchtop enzyme research. And that led to me doing my first presentation at the International Association of Dental Research, presenting a poster on the research that I worked on, did some summer studies with some dental faculty back at the dental school. And then during my sophomore year, Dr. Dom DiPaolo, who has since passed away, he was the dean at New Jersey Dental School at the time. He called me into his office one day, and back in the day when we had mailboxes and no email, you got a note in your mailbox and it said, the dean would like to see you at 2:00. You pretty much started to pack your locker up. You thought you were being, escorted out the building. So I went in to see him, and it was really a great conversation. And he asked me if I would be interested in being the first student to enroll in a combined DMD PhD program he had put together with the medical school. And he said, you've been doing research, you seem to enjoy it. Is this something that you'd like to pursue? And I'd been thinking about that after dental school, Howard, not to do while I was in dental school. I said, let me finish dental school first. But there was a scholarship involved and there was some financial incentive. So I decided to take the plunge. And that's really what got me involved with doing research. But I also loved the clinical dentistry. And so I continued to obviously do that even after I finished and I was teaching at the school. I went to work with someone else in their private practice and actually, I was able to have the best of both worlds.
You talked about the dean passing away. We lost another one, Anthony Volpe, retired.
Oh, Tony Volpe, yeah. Tony was a mentor and dear friend, probably one of the biggest influences in my life. I remember another dental school story, if you don't mind. I remember as a second year or third year dental student sitting in lunchtime seminar where they, you were chewing on some cold pizza and someone was coming in to talk to you. And it was this guy, Dr. Volpe from Colgate. And he was there, telling us about his career leaving dental school. He was an alumnus of the dental school at New Jersey. He was in the charter class. Talked about his career at Colgate and how, how he was able to use his dental training and go into a corporate environment to be very successful. And I remember turning to one of my good friends, who I'm not going to call out on this because I don't want to embarrass them, but I turned to him and I said, I will never, ever work for a company over my dead body, in a sense. And sure enough, in 2005, who recruits me to come work at Colgate but Tony Volpe? And he just continued to be a force in my life while I was at the company and after he retired. And I actually spoke to him this summer. His wife passed away a couple of months before he did. And I found out about it because he was a very private man and it wasn't really well known. And I called him because one of the things he always said to me when I was at Colgate, was like, enjoy Colgate, learn what you can here. It's a great company, great people. And I did. I would not trade in my 12 plus years, almost 13 years that I had with Colgate for anything, because I learned a lot and actually use a lot of those skills every day in my current job. But my passion was education. And he said, you need to go back and become a dean of a school. And I was like, I don't know if I want to become a dean. That's a big job. I don't want to, And so when I finally became the interim dean this past summer, I reached out and I called him and I found out just prior to calling him about his wife. And I told him, I said, and we were crying on the phone. I was crying on the phone as I was talking to him because, it was his dream to see me achieve this. And it was such an honor to be able to tell him it finally happened and that I had arrived at this role. And then shortly thereafter, he passed away as well. So it's a day doesn't go by that I don't think about it.
And men should really think about this. I mean, Art Dugoni, he passed away right after his wife, Kay, of 66 years, passed away.
Right.
Pete Frouchette, the man who took Patterson Dental public and all that stuff, he passed away right after his wife did. Even Richard Nixon passed away, right? I mean, it's just very common that when a man's loses his wife, he's done. They just check out.
Yeah.
I mean, it's
and Art and Tony were very close friends too. They were sort of contemporaries within dentistry over the years. They had, each had their own path. I mean, Art in education, president of the ADA. I mean, he, did so much for the profession, and Tony did his part through his role in industry. And there was this kind of group of them. Don DiPaolo, I would include in that group. Mike Alfano, who just finished up a few years ago at NYU. There's this group that was kind of all around the same time, really strongly influencing the profession. And losing both of them so close to each other was a big blow.
Yeah, you probably shouldn't say all their names when you tell that story because it sounds like you're describing the Italian dental mafia.
Yeah, I know. I run into that. I run into that sometimes, but. Those were the folks that, there was definitely a lot of other people that have helped me get to where I am today and all across the board. And I really thank them for seeing something in me that they felt, there was an opportunity and there was a path forward for me and gave me those opportunities to kind of develop.
So, Foti, the benefits of us being old is nothing's our first rodeo, and HIV was a huge impact on dentistry, and it massively prepared us for this SARS. And what I was wondering is, what did the HIV pandemic, being a bloodborne virus, not really prepare us for SARS? And what do you think our reactions have been that are here to stay, that aren't going away? And what do you think are some of the overkills that are maybe fad in a pandemic? Like some oral surgeons are saying that they're all going to have to go to negative air pressure rooms, and others are saying just relax, just relax. So what did we learn from HIV that helped us today, and what's here to stay, and what's What's the future look like for these
Yeah,
airborne?
that's a great question. I've been thinking a fair amount about this, primarily kind of what are we going through right now and what's going to continue going forward. From the HIV perspective, I came into dental school right after that. So I remember when I first started dental school, that was when they started to introduce gloves into the curriculum. Okay, so I learned practicing with gloves. So it wasn't like I had one day I didn't have them and the next day I had to use them and deal with that learning curve. Um, excuse me. I think what we learned with HIV and bloodborne disease is that the protection really starts with first of all ensuring you understand the medical history of the patient, not that you would treat them any differently. And in fact, even though the patient may not be positive for bloodborne disease that you're aware of, you need to treat them as such. And I think that's the first mind shift, that every patient that sits in the chair could potentially be infectious. And so we have to do the same thing from patient to patient. And then obviously all the barriers that we put in, whether they're personal protective equipment or other mitigating steps that we took, then became sort of the standard. And now we wouldn't think about going backwards. If all the bloodborne diseases were somehow eradicated, I don't think people would be throwing their gloves out of their office windows and, sensing freedom or something. I think we would continue to practice the way we're practicing. Looking at what COVID has done for us, and to be honest with you, we probably should have been thinking about it maybe a little bit more with SARS and, when that came out a few years ago. But, it wasn't as prevalent in the population. It was very isolated, so it didn't really raise to the level of causing any changes. But I think at this point, what we are going to move forward with is that we need to consider every patient as potentially having a respiratory disease that could be fatal if you contract it, and therefore we need to do whatever we can to mitigate that exposure. And that could be the masks that we're using, face shields, the evacuation system, making sure we have an adequate evacuation system, and then maybe even a slightly higher level of screening of patients, maybe with some of the chairside kits that are coming out that may be validated for use. So I don't see us going back at all from those kinds of steps we're doing right now. And then obviously turning over the office and so forth. This morning I was on a call with my counterparts here at Health Sciences, the other deans. We have a weekly call about COVID and other things. And one of the things I brought up is that, for the last 6 months, and I'm sure you follow Marco Vujicic and his team out of Health Policy Institute at the ADA, and I listen to their podcasts religiously when they come on and I read their reports. We've sort of reached this 75 to 80% activity level in practices versus pre-COVID. And it hasn't really budged too much in the last 6 or 7 months. And the question I have, I guess, for you, because you're more tied into the practicing community, is this sort of the new reality as well? Or are we going to be seeing that creep up closer to where we were pre-COVID at some point in the future? What's the sense you're getting from the dental town community?
That's a really good question. It all comes down to operators. The DSOs who have a layer of management, the owner-operator dentist, he's got to be HR, legal, marketing, all these things like that. There's a lot. I'd say on average, they're the ones down 20-25%. But all the DSOs I go to that have this upper layer of admin and marketing and administration and all that kind of stuff, they're all past their COVID levels. I mean, Rick Workman has 300 Comfort Dentals, and this is a record year. Same with Heartland. I mean, they're crushing it. And then when my friends that I've podcasted and the ones I know that are just really good owner operators, last year, they weren't even down for last year, and they were closed 2 months. So I think that, my gosh, it's kind of like orthodontists always felt they were competing with general dentists until a do-it-yourself ortho came out, and now they're like, oh, well, now we're allies, and we need to go fight these two together. Your enemy's friend is your enemy. And the DSOs, which just has the, this bad reputation because dentists want to be, the American cowboy, owner, operator, solo practice. I get it, all that kind of stuff. But man, once the pandemic came out, they can't sell their practices fast enough to Heartland and others. They're just selling them right and left. MB2 out here, and MB2 just sold yesterday. Did you see that? MB2, which is...
Yeah, I saw that in the afternoon, the Becker's review that comes out. They kind of highlight, I think that was in there. Yeah. Yeah,
and they're Sentinel Capital Partners, private equity firm, sold it, and that was like the sixth DSO that went for record. So again, it comes down to execution, and a lot of dentists are like you, where they love the research, they love the science. They went to school for 8 years to have healing hands and help the patient, and it's another breed to sit there and understand EBITDA and earnings and profit and marketing and growth and all this kind of stuff like that. And it'll be interesting times. And another interesting time is with the dental schools is I know I don't think you can have 2 doctorates and not have a love for technology. But you love technology. But it seems like whenever a dental school goes out and says, we're going to adopt this technology and we're going to do this and we're going to roll it in, then on Dental Town, everybody's screaming, oh my God, that's why tuition's so high and these kids are graduating $400,000 in debt. So I want you to touch on that 400-pound elephant in the room, where the rising cost of dental education and the student loan debt versus someone like you who wants to be the dean, who loves research, and every time you roll out some technology, they're just going to point back to the cost of it, which I think is absurd, because if you think your student loans are a lot of money, wait till you get divorced. I mean, my God, I would have given anything if my divorce cost me the same as dental school. So how do you wrap your head around all that?
So there's a few questions in there, and typical of you, Howard, you always kind of make it a very complex question. So I'm going to try to break it up and answer it for you, okay? So first of all, our tuition here at the school is not driven by technology and acquisitions and so forth. Our tuition is really, we have a set tuition, and the increase is really set by the university. We do not unilaterally increase our tuition based on what we're doing. Private institutions may have that ability, but as a land grant state institution, the university tells us kind of what our capabilities are relative to tuition. And to be honest with you, I don't want to raise tuition. I think our students are paying enough already for the education that they're getting. And actually, as a separate point, one of the things I'd like to do, and if I'm in this position, for the foreseeable future, is I want to see us increase the amount of scholarships we're getting in for our students, both in number and in dollars. Because if we can help offset some of the cost of their education, I think that's going to be a huge win all around. When it comes to technology, though, we as an educational institution, our responsibility is to educate and train competent general dentists when they come out of school. That's our mission. Then if they want to go on for a specialty or do whatever, that's fine. But our responsibility is competent general dentists, and here, because we have a 4-year hygiene program, competent dental hygienists coming out, starting, entry level. Part of that is to know what technology exists in the office and the technology that, we use every day. If we're not using it here at the school, they're not going to be able to use it when they go into practice, whether they go in as an associate, or maybe they buy a practice, whatever they end up doing, even after their postgraduate education. One of the things we've accomplished here at the school, and we've accomplished the goal here at the school, is we have a Center for Research and Education in Technology, or CREET Center, and you can Google that if you'd like and look it up and see. We're one of 3 schools in the country that have one of these. And it's actually, in a sense, a private practice setting set up in an extramural site that we have, where we have some of our postgraduate programs. And the students rotate through that center and treat patients in what you and I would consider a modern, technology-enabled private practice. And they get to do everything from CAD/CAM, digital scanning, milling, CBCT, all the things that are becoming mainstay, or are mainstay in practice today. and they really get a handle on all of that. And we're actually incorporating now that technology in our clinics in the main part of the school, as well as in our simulation lab, so the students get to start using it while they're still in that early stage of their first 2 years. So it's a phasic process that we're doing to roll this out. You talked to Dr. Shinkaglia recently, and he talked a little bit about the implant surgical robot, the YOMI system that we just got. We're the second school in the country to acquire this, actually in the world, and that's proving to be a huge boon for our implant practice, and is allowing us to do things that we weren't able to do before in a more accurate way. And I'm not going to go back into it because I think you did a great job on that episode with you, and I would ask people to go and listen to what he had to share with you, because I think it's really important. But on the horizon, there's this whole, and we've been dabbling in virtual reality in dentistry for about 10 or 15 years, but I think we finally got to a point where there's some technology coming out that within the next 3 to 5 years, that virtual technology will allow us to augment what we're currently doing in the educational programs. It's not going to replace the simulation lab. It's not going to replace treating real patients. It's just going to be another way for students to be able to hone their skills in a manner where it's not only easy to do and provides feedback, but it can also allow them to recognize when they make a mistake, to back up in the clinical process and try that step again. Because in virtual reality, you can do anything, right? So you can move forward, move back in the process, and say you're prepping a crown, and all of a sudden, as you're prepping it, you realize you dropped the margin too low, and you're starting to violate the biological width. Well, you can rewind the tape in the virtual reality system and go back to before you finish that margin and redo it and do it correctly that time, because it'll tell you, hey, you did something wrong here. So you get that feedback. So I think that's the next phase of what we're going to be seeing. And I think as a school, we're obligated to keep our eye on the future and what's coming out, and also to determine as a faculty, as a group, what do we want to put our efforts into, and what do we want to put our limited resources into to help train the next generation of dentists and dental hygienists.
You were talking about the ADA, and love their economist there. That guy is just so amazing. But going back to the ADA, I mean, I'm sure you thought of this, but the first president of the ADA was a double doctorate like you, but he was a DDS MD in 1815 to 1891, William Henry Atkinson. And now the current president of the ADA is right here from Arizona, Dan Clementson. He's also an MD DDS. The United Kingdom, they have 13 specialties, and you can't be an oral surgeon if you're not a double doctorate. And I was wondering if you and Clay Marsh, who's the dean of the medical school, while you're going for the dean of the dental school, I wonder if you guys would ever consider going back in time and saying maybe it's time to get married again and we should have never got divorced and hook up. Why is dental school, why does West Virginia have a medical school and a dental school when the mouth is part of the human body? I mean, it just doesn't make any sense looking back.
Yeah.
How did we get here, and do you think you'll ever go back?
I'm not sure if we're ever going to go back. I think what we can look, though, is to move forward and to work collaboratively with our colleagues in the medical professions. I think being in a health sciences center, which we are, we're one of 5 schools plus a hospital. We've got medicine, dentistry, nursing, pharmacy, and public health. And we're already doing a number of interdisciplinary, interprofessional programs with these other schools, but I think there's opportunities to do more so that people have their specialty, have their area of responsibility, but gain an appreciation and understand what the other folks are doing. And you don't get that other than putting them together and having them work together on a case, on a patient. So for example, one of the initiatives that we're currently kicking off, we have a cancer institute here at WVU. It's one of the biggest ones in the area. A lot of patients come here for treatment. We know, and I know the sequelae to radiation and chemotherapy relative to the oral cavity. And if there's any active disease before that treatment begins, you want to get it under control. So we've been we have a process where people are referred, but it's not really a formal process, and we're really not, we're not part of the grand rounds in talking about case management. And so I reached out to the director of the Cancer Institute recently, and I said, I have faculty here who are really interested in forming a service for your patients and to formalize it so that we can bring the patients over for pre, during, and post chemotherapy management of their oral health. And it was almost like they had been talking about it, but they hadn't moved on it. And my simple email kind of spurred, okay, let's get this together. And now we're going to get together and we're going to make this a reality. I have a colleague who runs the medical school in the eastern part of the state, the Panhandle, sort of over by Maryland. And they have a smaller teaching hospital there, but they have a lot of patients who have diabetes and heart disease, a lot of metabolic problems who need oral care. And in the area, there are very few people that they can go to because of the lack of insurance and coverage. And so we've been talking, and right before COVID, we were planning to try to establish a clinic, a dental school clinic on her campus, where we would affiliate with her medical school and hospital to provide that resource for those patients. And we were thinking, maybe we would do an extension of our GPR program, or maybe start an AEGD program, something where we would have residents along with some faculty supervising. I think that's the future, Howard. That's the future of how we work with our medicine colleagues. I'm not as concerned personally about becoming a specialty of medicine. I'm happy staying the way we are, but we can't stay isolated either. We have to become more collaborative and more integrated with our medical colleagues. And I know that brings up a lot of concern on the part of private practitioners when it comes to insurance and all the all the issues of whether it's Medicaid or Medicare, and that raises some concerns, and I understand those as well. But I think that's really where the future is today.
Well, it's very complex, as everybody at the end of the day only thinks of themselves. Like the patient wants everything for free. That's completely irrational. I mean, it's just crazy. I know a bunch of rich dentists who get mad if you post an article to Wall Street Journal where you have to have a paywall. They're like, "Oh, dude, you have to subscribe." And it's like, well, hello, you want the journalist to work for free? So the patient wants to eat chocolate and drink Coke, and they get everything for free. The dentists don't want any competition. I mean, my gosh, I'm here in Arizona, across the street from the Guadalupe Indian Reservation, with 25,000 humans that deserve a dentist, and they're too poor to have a dentist. And every time a dentist from Mexico comes up and sets up practice, the Arizona State Board of Dental Examiners, and that he's arrested and deported. And it's like, so that's, if you're really concerned about the poor, why do you have to have a dental license to practice? Couldn't I be a consumer and say, well, I'm going to go to Howard because he's high-end, more expensive, nicer car, and why can't the poor have a dentist practice from their own country like the first 100 years? So they're just very, very complex issues that are hard to solve. So where do you think the role of this dental education? Do you see any changes on the horizon? I mean, after the pandemic and everything that's going on, do you see any big fundamental forces changing dental education on the horizon?
I don't think there's anything like, earth-shattering that's going to come out of this. I think what we're going to see is there will be some incremental changes, and I'm happy to kind of give you my thoughts on that in a moment. I also think there might be some not groundbreaking, but kind of big for dentistry changes going forward. I think one area is the area of licensure, and the idea of taking a licensure exam as part of the process to get a license in a state in which you want to practice. The licensing boards have done away with the live patients. This year, all our students who take CETA or CERTA here at the school are going to be doing a total mannequin based licensure this year because of because of COVID. I think this is probably a step in the right direction relative to some changes. I think we're always going to have some sort of a licensure process, but I know for a fact, having the mannequin exercise does remove a factor from the students having to get a patient, making sure the patient is going to show up the day of the exam. Some of them have to pay their patients. Some of them have to put them up in hotels. There's this expense, this hidden expense that we all kind of acknowledge, but we don't do anything about. And so I think that is going to be one of the things that we'll see hopefully maybe change as state boards allow both, these mannequin exams to be acceptable across the board, as well as some of the other exam modalities that are coming out from different groups that are coming together to make that happen. Some of the more incremental changes I think that you'll see, and we're kind of exploring this right now with our students, we're asking them, we've moved a lot of your curriculum online. Some of it is delivered live in a synchronous fashion. Some of it is asynchronous. You learn at your own pace. You go on, you watch a recorded video. What do you prefer? What's your preference? And we're kind of hearing from our students somewhat of a mixed bag. There are some topics that they feel having a banked archive of lectures that they have to go through at their own pace is actually the best way for them to learn. They can review the material when they're ready to review it. They can stop it, rewind it, go 1.5 times speed, take notes without, worrying about the person saying it and passing it by. But there are other classes, like classes that are associated with the simulation lab, that they'd like to have the class, right before in person with the faculty before they go into the lab. And then with the courses that are fully online, they still want some component where they're together discussing the material with the faculty members. And so that could be case conferences, it could be simulation reviews, there's all different modalities. So I think we're going to see some of that happening in the curriculum. What that will open up, Howard, is for schools to work together on curriculum. Where I could partner with 3 other schools to deliver the pharmacology course to our students. We pool our resources. We each maybe have a faculty member at our school who's responsible for working with our students, but maybe the content is content that we all share and we all put in together and develop. And that may prove to provide some efficiencies relative to delivering the curriculum. So that's some of the incremental changes that I think we're going to see. Interviewing for candidates. We've seen an increase in the number of interviews that we're doing because it's virtual. A student now can apply to WVU if they really want to come here if they live in Colorado. Maybe they didn't apply because they don't want to travel and the expense of the interview and coming in person. While it's not ideal, our team, our admissions team is kind of seeing that, we're interviewing a lot more people outside of, within driving distance or within a short flight of coming to Morgantown. So I think that's going to be something that's going to change going forward as well. And then I think lastly, and this is totally on the continuing education side, which you have a huge library of continuing education that you all provide through Dentaltown. This is going to become more of how education is delivered to the practicing community. We're still going to have our meetings. We're still going to get together in Vegas or in San Francisco or in Chicago. But I think a lot more content is going to be delivered in this fashion as well, using video technology. And it's going to get more sophisticated to allow interaction. And I think that's the real opportunity. So those are just a few of the things that I see, potentially happening coming out of the pandemic.
The thing that I think the pandemic illuminated to me so much is I graduated from high school in 1980. Now it's 2021. It's 40 years. It just seems like trust in institutions has just been going down my entire life. I mean, I've watched 40 years of all things holy and sacred just one by one just coming down, and now trust is just it's so bad. And like even the what you were involved with triclosan. I mean, you would sit there and say, here's the research, here's the studies, and then there was so many people on Facebook. I mean, that was, I don't know, it was kind of like an anti-vaxxer deal about triclosan. In fact, I want you to address triclosan. I know there's still dentists who think antibacterial soap and triclosan is not a good idea. What are your thoughts on that?
Well, again, trained as a scientist, I follow the science, and the science indicated that in Colgate Total, when it did contain triclosan, it was safe and effective for what it was being used for. Having triclosan in other products like hand soaps, the hand soap issue, Howard, was that there was no science behind whether adding triclosan actually provided more of a benefit than the soap alone. And that's kind of why they pulled it out of soap, because the companies that were producing triclosan containing soap had an opportunity to do the research and show that, if we add triclosan, we're getting that much more of a benefit over soap alone, and it's also safe. They didn't either do the research. I'm not sure. I left the company before all that was all happening, so I didn't follow it as closely after I left. But as far as it being in the dentifrice, very safe and effective, and the research, went to prove it. I mean, we talked about Tony Volpe earlier. He devoted probably half of his life doing research on triclosan, clinical research and safety research to prove that it was safe and effective. And was the only oral care product ever to go through a new drug application with the FDA, like a heart medication or, something for diabetes goes through. So, I mean, that's the standard that they had to meet. And so to me, that demonstrated that the science, was supportive of it, and it was safe and effective to use. But I mean, the public opinion and the opinion of professionals, those vocal individuals, did drive the narrative for many years around that product, and I had to deal with it on a regular basis. I think what was really refreshing, but also not surprising, was that organized dentistry, ADA, the ADHA, the Hygiene Association, AGD, AAP, all these organizations that, I had a pleasure of working with, and some of them being a member of over the years at Colgate, really came to bat for us when there was a controversy. They were also steeped in the science and said, listen, this is, to their members. And I think that was really, really important. And I think that's something that isn't always recognized, the role that those organizations played in supporting the science.
Not to make you feel too uncomfortable or whatever, but there's I'm sure this will be a dental school dean admissions question, but Iowa is their students are protesting in the streets, and it's making national news. I wonder what you think of that.
I wasn't aware of the protest. Can you fill me in on what's happening there?
Yeah, there was an email thread within the College of Dentistry community, a Starks debate about where professors and students debated the purpose of an executive order. It had to do with politics, and then the here, let me see the last. University of Iowa dental students demand change despite legislative blowback. Fourth-year dental student Jasmine Butler, second from right, and third-year dental student Mega Perman lead protesters in Chance Friday as they march to the University of Iowa College of Dentistry during a Put Diversity, Equity, Inclusion, and DDS. DEI and DDS walkout. The protest was discussed earlier this week by lawmakers and Iowa House Oversight Committee, but it's well, you know, I'm from Kansas, so I probably get more Iowa news. But third-year dental student listens to speakers Friday during a walkout at the University College. But anyway, they want more. It says, don't teach me how to respond to hate. Teach them not to discriminate. Yeah, that's one of their slogans. Don't teach me how to respond to hate. Teach them how to not to discriminate. Your innovation speaks louder. But anyway, it's diversity and education. Yeah. What are your thoughts on that?
Obviously, that's a huge topic across all of education. I think all of society. I mean, after we saw what happened to George Floyd this summer, and others, you know, which, you know, to me were, you know, I think they were, you know, seminal points sort of in this entire diversity, equity, and inclusion that kind of crystallized it for many of us. And I think having the pandemic on top of it, you know, just amplified the reaction that people had, and rightly so. Social justice is a huge an important issue within education and here within the university and within our school. We have a diversity, equity, and inclusion committee that actually takes an active role in promoting DEI related activities and programming and functions to ensure that people are aware that this is an important issue and that, you know, we have to be respectful of each other. We have to understand where each other comes from. We have to understand that, you know, we all have implicit biases and we need to learn about them so we can address them effectively. And, you know, we've actually even put together a curriculum that will hopefully get launched later this year. I haven't really formally brought it to the school yet, and I'm hopefully going to share that shortly. So for those that see it, they got a little preview, but it is a comprehensive program to address this from a curricular standpoint so we can actually incorporate different programmatic elements within our education to actually talk about these things. You know, and so, and that goes from educating the students to recruitment and retention of faculty and staff and students to enhance the diversity of the population here. All of those are key components of this. So I can't speak to exactly what's happening at Iowa because other than what you've told me, I wasn't aware of it. I can tell you though, here at the university, starting with our president, Gordon Gee, on down, this is a common thread throughout the entire university. And I'm proud of the steps that the university has taken that they had in place before everything that happened last year, but as they've continued to lead appropriately in addressing this issue. So, you know, it's an ongoing program here, and I'm really proud of the faculty, staff, and students here at the school for their support of our efforts. As I am, just to say in general, proud of what they've accomplished under the pandemic. You know, I always say it's not me, it's them. They were the ones who made this happen. I just was able to provide the environment through my role to allow them to do the job that they're doing. So,
well, I always say you shouldn't talk about religion, sex, politics, or violence, but it's a dental school, and I have to broach politics. But basically, the whole thing started on October 19th of last year. Megan Purnam was sitting in her classroom, rotating through her clinics as a third-year University of Iowa dental student. While waiting for patients to arrive, she observed conversations about an email thread earlier that weekend in which her fellow classmates were debating the college's decision to condemn President Trump's executive order that placed a halt on diversity, equity, and inclusion training programs at the University of Iowa. After hearing her peers in the classroom speak to her about cultural competency and diversity, equity, and inclusion not having a place at the UI, she left the room feeling hurt and discriminated against. She says, "I left the room crying. I cried twice." Purnam, a proud Indian American woman, said the third time I sought counseling. But, you know, I have to give credit to the dean out here, Jack Dillenberg, who started this AT Dental School. You know, when I got here in '87, the Indian reservations were always trying to recruit dentists to go work on the Indian reservations. And it was Jack that said, well, why don't they have Indian dentists? Well, they didn't make the cutoff, or they didn't get accepted, or whatever. And Jack just said, if anybody from these reservations applies to dental school, I'm gonna work with them and help them and get through it. And now, I mean, imagine if I was a little baby Navajo. I wouldn't want to go to some fat, bald Irish guy like me that didn't know a word of Navajo, I'd want to go to someone that spoke my language and knew my traditions and all that kind of stuff like that. And it's these are ugly conversations that have to be addressed, but there's just no, it's just so complex, man. These are such strange times between the political and now coming the economic. I mean, right now, price earnings ratio. I mean, I went to Creighton University in Omaha. Warren Buffett came and lectured at our class in 1980 School of Business. And, he likes to buy stocks at 6 to 8 times earnings. And I remember, being an Irish descendant, that if you couldn't get a ride to America from Ireland, you could be an indentured servant for about the same period of time, about 6 to 8 years, that you get a ride over here and you have to be someone's worker. And about 6 to 8 years is what a price earnings is. And Tesla's this morning is 1,500. I mean, to say that, when people say we're not in a market bubble and it's sustainable, I could sell Tesla stock and buy 100% of all the other car companies, Volvo, Mercedes, Porsche, Ford, Chrysler. Not to mention, when I drove 30 minutes into work today, I didn't see one Tesla on the road, but I passed so many F-150 pickup trucks. So these are just insane times in politics, economics, biology, a pandemic. My gosh, it's how do you keep it together? I know you're a big runner. What have you done, like 55 marathons in your lifetime? Is that where you get your yah-yahs out? Do you just, when you can't take it anymore, you just go run?
Yeah, running is a great release. I also do a daily meditation practice, which helps also. It is challenging times, and a few people, well, maybe more than a few, when they heard I took over as interim dean, their first question was, why would you become a dean right now? This is probably one of the worst times to be the head of an institution. And I can understand. I mean, it was a little tongue in cheek. I know they were joking for the most part, but it is a question that you ponder. I feel today, for me, what's important as a leader is to set the tone for the institution, to actually set sort of the demeanor of the institution, and how the institution will sort of, it's a little nebulous. It's hard to describe, but I think, for me personally, it's all about interaction, collaboration, going out, talking to people, meeting with them, not sitting in my office if at all possible, and getting out and interacting. I still teach 2 half days a week in our clinical program because that's my love, first off, and I enjoy being in the clinic with the students. But the political and social unrest that we've been experiencing put leaders in very difficult positions, because you often are expected to say something about what's happening, but you have to say it in such a way that you don't offend a lot of people. You try to offend as few as possible. You're never going to not offend everybody. There's always going to be a few that are going to take exception. And I actually received some feedback recently regarding what happened on January 6th at the Capitol, and I made mention of it. I put a Friday email out to the school, just kind of an update, what's happened, new people who joined the school, people who've achieved something, some COVID updates, whatever. And I actually wrote a little bit about what I saw and my personal reaction to it, not casting dispersions or trying to make anyone feel bad about what happened, and or that if they agreed with what was happening or was at least appreciative of it, of what was happening. And I was told, we hear enough of this, Dr. P, and we'd appreciate it if you didn't include those kinds of comments. Sort of, that was the feedback. And initially I was a little hurt over that, but then I kind of thought about it, and I said, don't be hurt. As a leader, sometimes you have to say certain things that's not going to be pleasing to everybody. That's part of being a leader. And the right thing to do is, if something does happen, to acknowledge it and to, frame it in a context that is as neutral as possible, but also, recognizing that there was an issue. I mean, I did the same thing over the summer with the social unrest. That was, it wasn't like a common thread in every email, but I did make mention of it, and then I moved on. And I think that's what a good leader does. So it is tough times, but I am, I'm honored to be leading this great school and to be working with a wonderful team of people here, faculty and staff, and we have an outstanding group of students. I'm so proud of them and what they're accomplishing in spite of all the challenges. And I really feel this is where I was meant to be at this point in my life, and I'm just glad that I'm able to do something that I really love.
Well, I think dentistry is lucky to have you. I mean, I've been watching you, studying you for the whole time. Trish O'Hare was, I mean,
I remember working with her for many years when I was at Colgate. That was, with Trish.
Oh, yeah. And she worked for me for 10 years with Hygiene Town. And
right.
In fact, my last question is going to be about Trish. When people are talking about toothpaste, she always reminded everybody that dry brushing is fine, that you don't even need toothpaste, and that if you brush for 2 minutes without any toothpaste, you're going to remove all the plaque and do everything you're supposed to do. Right. What did you think of Trish and her love for dry brushing?
I never argued with her because the science proves that it's the mechanical action of the brush that actually provides the benefit. I guess what I would counter to her was, do you want to provide something in the dentifrice, like when Colgate Total had triclosan, or even now with Stannis to a certain regard, but probably not as effective, of having some protection post-brushing? Prevent the buildup of the plaque as much as possible before the person brushes again, say 12 hours later. That was my only counter to what she was saying. Otherwise, yeah, mechanical cleaning is the gold standard. I mean, that's, when you have a clinical study and you're studying a dentifrice with an active ingredient that's active against the biofilm, you're using a product, a dentifrice that has no active ingredient. In a sense, you're really testing the mechanical action of the brush in the control. The toothpaste with the fluoride does nothing to provide an anti-plaque benefit. As well, it may be very slight, but not measurable in the clinical study. So, yeah, so we I never dissed her for her thoughts in that, but I think, I kind of made a friendly amendment to her model by saying, but if you do include this and it does provide a benefit, you will see something improve for the patient going forward.
Well, I'm sure you're busier than a one-armed dentist, and thank you so much for taking an hour out of your day to spend with me and my homies. I thoroughly appreciate it, and good luck with those students, because the only thing is like my favorite deal in science is knowledge has no value unless you can pass it on, and being able to impart everything we've learned in dentistry into these young kids. And I also just want to say one thing about the dental students is every time I go on some missionary dental trip or I'm around a bunch of dental students, I always feel honored, because it's like, these are the guys that the people that chose our profession, and they're just class act. They're smarter than normal. They're nicer than normal. I'm always honored that I'm in the profession that these guys want to join. I mean, we're not being chased down by hillbillies. I mean, these are some amazing people. So good luck with the kids, and I hope you teach them everything they need to know.
Thanks, Howard. Always a pleasure. Good luck, and be well, and hopefully we can do this again, and we don't have to wait 3 or 4 years.
All right. I just hope it's not at a marathon. I don't want to talk to you during
that's okay.
All
righty. Be well.